Today we are here to discuss on low vision aid. Before going to this particular chapter, I have one great appeal to each one of you. We have got a journal, Indian Journal of Community Ophthalmology. I beg the contribution from each one of you on low vision aid, on whatever you are facing problems in your own areas. Today, I like to start the discussion with my keynote address on the necessity of understanding low vision aids for the community at large. It's a very simple answer in our day-to-day practice. As an ophthalmologist working in different medical colleges for the last 43 years, we have seen only one answer to the patient: nothing can be done. But we always say something can be done. So we have to change our attitude that nothing can be done. Whenever we like to find out or we diagnose a case of anophthalmos, we have got the only answer to the parents: nothing can be done. But that unfortunate parent like to sit in the outdoor until the end and always used to ask the ophthalmologist, "Sir, please do something, please do something." And the doctor has got only one answer: nothing can be done. And unfortunately, in India, right at this moment, we have got more than 1,000 blind schools. But another pity story is that only 2 to 3% of the ophthalmologists have got the idea about the location of the blind school. They have heard that there is system of blind school education for all those incurable blinds. But they have got no idea. They can only say, "Yes, I have heard that blind school." Even in the locality, they have got blind school, but they don't know the location. So the simple answer to each and everybody: nothing can be done. So we, the community ophthalmologists, like to say that something can be done. Keeping all these things in view, we like to start the discussion today. The necessity of understanding low vision aids for the community at large. You all know the common diagnosis in our LVA clinic are the retinal problems, the whole globe problem, the optic nerve, the corneal involvement, lens, as well as cortical blindness. And if we just go through the clinical profile of patients attending our LVA clinic in India, we can say that the most of the patients has got about 63.5% has got retinal problems in different degree. And if we just go through our Indian scenario of the causes of low vision aid, we can jolly well find out the retinal disease tops the list, and following that is amblyopia, optic atrophy, glaucoma, corneal disease, higher visual pathway lesions, congenital abnormality, and so many things. To give effect to the Indian Nation Convention on the Right of Persons with Disabilities in the year 2006, much more stress has been given on this particular aspect. And so many subcommittees have been formed, and one of the subcommittee is dealing with blindness and low vision aid. Now, the Ministry of Social Justice and Empowerment has also revised the definition of blindness and low vision rights of Persons with Disabilities Act in the year 2016. So from 2016, the definition of low vision aid has also been changed. And here are the guidelines what has been enacted in 2001, where we have got 5 categories of low vision eyes. And the main problem with this, that many patients falling in between 40 to 70%, and many patients not fitting in the option. Difficult for the doctors to categorize the patients, as well as they cannot depend only on the better eye alone. The worse eye status must have to be accounted for. That's why the new formula has come up, and this new categorization has been prepared by the Department of Community Ophthalmology, Rajendra Prasad Center for Ophthalmic Science, and that has been enacted by Government of India. You can jolly well know this particular disability matrix chart, and if you are interested, we can distribute it, this disability matrix chart, by which you can jolly well find out the percentage of the disability with a better eye as well as the worst eye. And this disability matrix is recommended to use Snellen's chart or its equivalent chart. and we always like to take the best possible correction, whether by medical, surgical or conventional practice. And after assessing best corrected visual acuity of both eyes, check the eye which is the better one, and in this way we can categorize the patient and give them the disability marking and handicap certificate with the percentage. And what is the percentage disability if the best corrected vision is in the right eye is 160 and left eye is 660. In that way we have to go through the better eye as well as the worst eye, whether it is 40% or it is 100% in that. In this particular aspect I like to mention that there are three types of blindness, what we like to call it. One is a social blindness. He cannot go on with his social activities. And the second one is absolute blindness, that no perception of light, absolute blindness. And in the meantime, there is another sort of blindness, medico-legal blindness. That means how much he is blind medico-legally. So we have to categorize the patient in three aspects, whether he is a total blind or medico-legally blind or he is a social blind. This is the disability matrix where you can jolly well find out a person with left eye 6/60 vision, but in the right eye having 160 vision, his disability marking will come around 60%. In that way, it will be excellent. It is our motto that if we can distribute the disability matrix to each and every ophthalmologist of India to keep it in their chamber, they can jolly well say the patient that how much percentage he can receive from the medical board he is just appearing. So this is 60% disability is, as per the revised guideline, is the benchmark for any disability marking. And next, coming to the visual field defect. You all know visual field defect, again less than 40 degree, less than 20 degree and less than 10 degree. And this is another matrix showing the visual field defect as the criteria to give any certification for visually handicapped. And in this way, this person with a visibility benchmark of disability means a person with not less than 40% disability. So 40% is not at all a benchmark for visually disabled. It should be more than 40%. So in this way we can give temporary or permanent certificate. Temporary means with those with mature cataract or something like this. In this way we can go on. And there are so many criteria, but the vision is multidimensional. You must have to keep it in mind. Distant, near, color vision, stereopsis, depth perception, contrast sensitivity, ocular motility and ocular reflexes. And the milestone of development of the eye is also maybe deprived or maybe disturbed with so many causes. And I do not like to go into all these details. I just like to show you a few cases of abnormalities of the eyeball which can make a child visually disabled and which we should look for. You all know microphthalmos, anophthalmos, these keratoconus, these microcornea, corneal problems like this. So many abnormalities in the anterior chamber, abnormalities of the iris, abnormalities of the choroid, abnormalities of retina, abnormalities of optic nerve, abnormalities of the lens, ectopia lentis and others, abnormalities of the eyelids and monocular elevation disorders, amblyopia and others, abnormalities of the orbit, abnormalities of pigmentation of the eye, oculocutaneous albinism, this is one. And we have found out some candidate gene for that in our studies in Bankura and other areas. In that way, ocular motility problem, night blindness and visual abnormalities, so and so with pediatric age group, neck pain, abnormal posture, amblyopia. And with this we are showing some low visual aids which can improve their vision partly. And we are lucky enough to be here in Dehradun, and Dehradun has got a very big national institute for this visually handicapped as well as developing low visual aids. And here are all low visual aids, household device. This may be optical, telescope and outreach, and this glare and others, contrast sensitivity. Now, here is one project which has been taken up in West Bengal in some 10 districts to find out how many persons are there with low visions, and these persons under this project has been taken into the hospital to check their vision and to check how much benefit they can get with the low vision aid, and afterwards they had been distributed with low vision aid, and afterwards some follow-up has been done that how much successful it is to have them rehabilitated in their social life with activities to earn their own livelihood. In that way, I don't like to go into this process. This model we can replicate in other parts of India also, and AIOCMT can take this particular type of camp and advocacy for the persons with low vision aid and can go on with successful networking with education department of the particular state and others. So, lastly, the take-home message should be meticulous history-taking, genetic counseling, prenatal diagnosis, postnatal care, multidisciplinary approach, early detection and introduction of low vision devices, preparing individual education plan and certification. And in this way, we can make low vision devices affordable and accessible to the masses. No more today. I'm really thankful to my good friend, Professor Suraj Senjim of RP Center, who is looking after this particular aspect of low vision aid all India, as well as Dr. Ashim Shil of West Bengal, who is looking after the project in West Bengal, for providing me some slides of this particular lecture, as well as helping me all the time with so many inputs. Once again, I like to recall you to assemble in Palampur Rotary Eye Hospital on 10th, 11th and 12th October in our next annual conference and our International Assembly of Community Ophthalmologists under the guidance of Professor B.N.R. Subuddhi as well as Dr. Lakesh Madaria. Thank you very much. Thank you once again. Thank you. Thank you.
Thank you, Dr. Samanta, for sharing your knowledge and excellent presentation of your work. You are a dedicated ophthalmologist in the field of community ophthalmology. Very few doctors want to work in the field of community ophthalmology, and Dr. Samanta sir is one of them. So he is highly motivating, and because of that, a coin is growing day by day. So now we are starting in testing session, this low vision aids, and first speaker